morning, everyone. I extend a very
Recording
warm
in
welcome
progress.
to all the representatives of various patient support groups we have today here physically, and to all our online audience and to all the faculty who has come here to join us in this patient support group meeting. I think it's a matter of pride and pleasure for all the members of patient support group of ISBMT that we are holding this first physical or rather hybrid meeting in the prestigious ISBMT annual conference. And with this, I will hand over to Dr. Venkatesh for the welcome address and for the roundtable discussion, which is going to be the first session.
Thank you, Dr. Silky. At the outset, I welcome all the members, all the participants on behalf of various patient support groups. I'm Dr. Venkatesh, and it has been a privilege to host you since the last 1 year online, discussing patient-related queries and problems that patients face when in their journey towards their cure through a bone marrow transplant. Uh, at the outset, when we started this initiative conceived by Dr. Revati ma'am from the ISBMT, the entire emphasis has been to uh, try to enable and empower patients and in their journey towards the cure through a bone marrow transplant. And we are so privileged to have connected with such illustrious and esteemed panelists that we have today from various patient support groups. So I welcome all of them and thank all of them for being such active participants through the last 1 year. We have conducted 9 webinar sessions, and this is the first time that we are meeting in person. The idea behind today's meeting is to chart our course for the next 1 year. So far, ISBMT uh, initiated these meetings based on a understanding of patient-related problems, but now is the time that the actual support group members initiate a course where they are actively setting the agenda and trying to help more patients through a dialogue between the physicians and nurses and support staff from ISBMT, and in fact, in the process, guiding ISBMT to take this forward in a patient-centric manner. And to do that for with us, we have uh, our panelists for today. But before that, I want to thank the executive body of ISBMT for supporting this initiative, Dr. Shashikant Apte, the president of ISBMT, Dr. Tapan Saikia, the director Department of Oncosciences, Jaslok Hospital, and Dr. Revati Raj, consultant pediatric hemato-oncologist and a pioneer in pediatric transplants. And I want to thank all the members for so far being active contributors, Dr. Silky, Ms. Riya Daruwala, our psycho-oncologist, Suman ma'am, our nursing support, and to kick off the session where I'll be inviting the panelists to share their thoughts. I invite Mr. Neeraj Trivedi to start his session.
Wow. So first of all, I think it's a great honor to be here. And I really thank everybody who's kind of been behind this. I think Raghu, Dr. Melankari, the entire Pune gang, Dr. Venkatesh, Dr. Revati, and all of them for having invited us. My name is Neeraj Trivedi. And so I was in the corporate for quite some time. And then I went into the social field. So for the last 10 years, I've been to social space and have worked on quite a few projects across India. I'm also a certified patient advocate by the National Cancer Grid and Patients Engage, which happened very recently. And I'm going to talk about this later on. And currently I work as a consultant because of my finance background and my management background. I help NGOs to streamline their capacity building, funding. And also there's a new concept that's called social stock exchange. So help them to go onto social stock exchange by kind of building that. So yeah, so thank you for this slide. And So these are the three, I think, key areas that we work on, and I'm going to talk more about this. I think one of the most important things that we did is that we have collated a lot of good patient data that we did, and for 3 years we kept just taking on questions from the patients, and we converted that into a patient's handbook, which is a preliminary guide for somebody to talk to the patients when it kind of, when we speak about bone marrow transplant. We have over 500 copies distributed across India and over 3,200 downloaded from our website. Our website has been reached by more than 10,000 patients. We've had, I think, about 36 odd seminars on BMT related to various topics. And we've had about more than 7,400 people viewing those videos to kind of, so that's the kind of, so we are not very impact focused. We are very quality, inch wide, mile deep focused. So we want to do excellent quality work and as little as we can, but we want to do very good work. The next thing that we launched was Swasti Astu. This was launched last year. It's an online portal where we thought that there's a lot of collaboration that is necessary across different groups. It could be myeloma groups, it could be leukemia group, lymphoma group. We have scattered information across every different websites. So we thought, why don't we have an open source copy left kind of a website where anybody can take any information and kind of process it for themselves. So we kind of created this entire online portal called Swasti Astu. And the third thing that we want to focus on is patient advocacy. How can we be a part of research guidelines, clinical guidelines, and right from the beginning, bring in a lived experience of the patient and a patient voice. And I think that was very critical to bring in that patient voice right in the beginning so that we know that the entire process that has been followed is kind of up to date. So, yeah. So I think that's pretty much what we do in the BMT space. And I think we'll talk more about it. But since we have exactly limited time, I think 3 minutes per person, I will stick to that. But really, thank you so much for the opportunity and look forward to working very closely with ISBMT in the future. Thank you.
Wonderful. Thank you so much for that work. I just want your inputs from you. Where this patient support group meetings would you like to go? Quick 2-3 pointers that you would like to address, ISBMT to address through this initiative. Those 2 points.
Sure. Yeah, I think that's very critical. Thank you. Thank you so much for, the clinician's perspective. They bring in, discipline where patient advocates miss out on. So thank you for bringing those points. I think one of the key things that we noticed during that is there were a lot of questions that kind of came from patients. We have listed, ma'am, Revati ma'am, this is also for your attention. We've listed 50 topics from different BMT questions that we want patient to address, And if I think if ISBMT is able to hold those webinars for us from a patient perspective, I think we could build, so even if, non-pressure, I think 50 per year, which is fortnightly or this thing. And I think we should kind of, so, but I think that's one thing that's really kind of important for us to kind of ISBMT to look at. And just one small input is that there are a lot of, we hold these patient circles. And sometimes many people have questions that you don't have a doctor on your panel. So even if monthly one doctor can be represented in the patient circle panel, they know that the answers we are giving are genuine, in spite of the fact that it's well researched. We have worked very hard to kind of collect the data. And last 5 years, at least at a personal commitment level, I have spent 1 hour every day in learning a new topic about BMT. So I think that's the kind of commitment that we have given, but still patients want to hear it from a physical, like a doctor's perspective in the BMT space. So I think these are 2 areas where, and the third is research and clinical guidelines. We were at the Credo workshop organized by Tata, Memorial Hospital, and we were distributed in different groups. And it was just amazing for us to learn what level of detailing goes into building a research project, and for them to understand how patients bring in their lived experience and how they can benefit from it. So for example, it was a small example about GVHD. And they said that we need to do blood tests 3 times a week and all that. So immediate question was, patient will not come to you. Can you send somebody home? So they said, oh yeah, we haven't thought about it. So I think those were some points where I think we could immediately build in those guidelines as they are formed. so that we could add more value.
Great. Thank you so much.
Thank you.
All right. We will definitely take those into consideration as we move forward. Next speaker will be Dr. Suman Jain, Chief Medical Research Officer and Secretary, Thalassemia and Sickle Cell Society, Hyderabad. Welcome.
Good morning, everyone. This is a very important place like patient discussion and all, and where we can present what work we are doing, and also the BMT, what patient wants from the doctors. So this society was formed under the guidance of late Dr. A.N. Krishna Kumari in 1998 with 20 children. And now we are having more than 4,000 children registered with us. So these are the roadmap, which I don't want to say. Like all the things has been done. Like we have got the blood bank, the diagnostic center, and the research lab, antenatal project, and one center at TSS Khammam. And also we want, our aim is to make thalassemia free Telangana, in long run thalassemia free India, which is quite possible. Next slide. So that is what I said. We have got the consultation, we have got the blood bank, investigations, other services, and BMT. We are getting it done in collaboration with Rainbow Children Hospital in Hyderabad and two centers in Bangalore. One is the Narayana Hridayalaya, another one is Sankalp India Foundation at Bhagwan Mahavir Hospital. And total number of transfusion we have done till today, 2,67,000, and donation camps 3,500. And we have done bone marrow transplantation 167, but the success rate is 85 to 90% in full match. And PND, prenatal diagnosis 435, and out of which 25% were thal-major fetuses, which we have to give an option to the parents whether they want to continue or not. And we have done the T2 star MRI 940, which knows what is the iron load in the patient. And this year, the new registration till today is 116. And total registered patients till today is 4,300. Antenatal screening, we have done 40,440 antenatal mothers. And we found the hemoglobinopathy is the 2.9 to 3.1% of the antenatal mothers were carrier. And their husband also were screened. And we could not go all the couples to go for prenatal diagnosis, but at least 80% of them, we could convince them to go for prenatal diagnosis. These are our team. And I want the key discussion points, Saroja to speak, because she is taking care of bone marrow transplantation patients counseling.
Saroja, ma'am, please.
Like we would like to emphasize more on limit. Like to encourage more extended family matching. So it would be better if we could encourage extended overcoming post-BMT complications by adopting better protocols with early interventions and long-term multidisciplinary follow-up care. We've come across cases where patients have been discharged home, but we couldn't follow up with them because of their remote areas that they come from. Hygiene was one of the major things that had to look into. And then the dosage, the medicines that they had to be taken. I think there was a lot of miscommunication, or their understanding level was low, so they couldn't take the medicines on time, and that led to rejections and deaths also. So that was one of the criteria which we would like to emphasize on. The other thing is maybe we could make registries with data. Like yesterday, we were hearing about the data about the percentage of the success rate in various transplant. I think we should have a separate entity for thalassemia and sickle cell anemia patients, where we would have a better analysis, where we would know how it is going on across the country. Thank you. Those things we would like to emphasize. I specifically would emphasize, we are very thankful that patient advocacy groups have been included, because initially it was just the hospital management and treatment, but patient advocacy groups play the major role in imparting proper information and guidance, because we don't blame the doctors. They don't have that much of time to give their patients. So I think together we can make a lot of difference in the outcomes, because those make a lot of difference. Thank you.
Thank you very much. Revati ma'am, would you share your thoughts on this? Let them all finish. Okay, wonderful. Thank you very much for these valuable inputs. I think what has come through is continuous flow of information between the doctors and the patients through their patient support groups. I think that is where the patient support group initiative has to come in. And we will take this forward through either through registries and through advocacy. Next slide, please. I now welcome Poonam Bagai ma'am to speak to us about her wonderful body of work over the years. Welcome her to the meeting.
Thank you very much. I'm Poonam Bagai. I'm a cancer survivor myself. And I'll use this one? Yeah. Okay. So I'm Poonam Bagai. I'm a cancer survivor myself. Set up CanKids for children with cancer, 0 to 19 years of age, and survivors of childhood cancer. I'm trying to see how this will move. Will you move the slide? Yeah. So we started a BMT awareness project. Actually, I think in around 2011-12, because there was a family and a father who was looking to get a transplant for his child. And he said, I have to get this transplant. But everybody has told me there is no need for the, I mean, you know, it's too late. We can't do the transplant, etc. And then he wanted to go to St. Jude and he wanted to raise the money. And he said, can we raise the money through CanKids? So that, you know, because you're an NGO. And all the doctors who were treating the child were, you know, the transplant is not indicated. But the father was so driven. And I think we know this. We all know this. A family, how driven they get if their child has cancer and they think they need a transplant. And then we realized that we don't have enough information. We don't know enough about pediatric transplants. We don't know where the transplants are happening. We don't know if the transplants that are happening are, you know, indicated or not indicated, right? And Dr. Revati is also part of our code medical advisory. And this is something that we all discussed, that we need to do awareness, we need to advocate, and only then we should be able to give patient support correctly. Otherwise, we're not able to give the patient support correctly. So this project started back then, and can you move the slide, please? And no, that's okay. You can move the slide, please. This is already done. And gradually, we have integrated the project into our work. So our work is essentially across hospitals. We partner with the treating hospital. And when we partner with a treating hospital, it is for best treatment, care, and support. And that includes be it transplant, be it survivorship, be it palliative care, whatever the services are. We provide social support services to the hospital. We provide social support teams to the hospital. And we are not only patient navigators, because we're holding the hands of the children and their families, but we're also patient advocates, because we keep working with the hospitals and the doctors to improve standards and to give the right kind of support. So today we work with 141 cancer centers across India in about 60 cities and about 22 states of the country. Next slide, please. So what were the goals? What were the goals? And this is not when the project started. This is when CanKids started. So this project started a little bit later, as I said, because of the father and that child. And we said we want to create awareness about pediatric HSCT, its indications, availability, etc., and disseminate the information to professionals, patients, and parents, and also survivors. You're a survivor, right? Yes, and to you. We want to advocate. So we want to make sure that treatment centers that are offering the transplant are offering transplants at a standard. And it's not just there's this one doctor. In fact, even till today, when somebody says, where should we get a transplant done? We say, please make sure that you know that there is a full transplant service, because it's not just enough to have just the one doctor. If you don't have the nurses, then you don't have a good transplant center. If the doctor isn't there, what will we do? If you don't have the full multi-speciality, you don't have the social support team, you will find it very, very difficult. If you're in that room for 1 month for your transplant with your child, it's difficult for the child and the parent as well as for the family. So advocacy was important. And then we do a whole patient support. We give financial assistance for families. And I'll show you in a minute what that financial assistance is. We also provide holistic care because that's our model. So we provide staff for the project. Next slide, please. So after we started it, we developed standards for the pediatric transplant centers. What should a good transplant center be for? And I'm talking only malignancies because that's all we do. What should be good standards? So we may be in a center where there is also thalassemia, also the other indications, aplastic, etc. Those we don't support, but we're obviously in the same transplant center. All of us are in the same transplant center. So today we have partnerships with about 28 transplant centers across the country. Next slide. And that's just to give you a quick snapshot. So how this process works is a transplant center or a doctor who we're already working with will reach out and say, we also want you to support transplant in our hospital. We give them our center questionnaire. They fill that up to say, yes, our transplant is up to this standard, etc. Our core medical advisory goes through the transplant questionnaire, tells us that, okay, this looks fine, go ahead with this particular transplant center. And then we enlist the transplant center. And thereafter, we provide support, we do awareness, etc., all the other parts of it. So go to the next slide, please. And that's the level of support that we're currently offering. So up to 2 lakhs for an autologous, up to 5 lakhs for an allo. We don't so far support MUD, and we don't really support haplo or the others. We're still looking at, and that's in my ask slide, how do we do the rest of it? What makes sense to do? We also do a lot of facilitation. So helping the families access the schemes. Right? And what are the schemes available across the country? You were just talking while you were walking about what are the schemes. And we have a whole facilitation service which collates this information. And I'd be happy to share it with the group as well in terms of which state offers what support for transplant, which state like Odisha supports transplant of children who come to NH, etc. Things like that. Can you go to the next slide?
Sorry.
I'm almost finished.
Yeah.
Yes.
Just 1 minute
Yes.
more. And your inputs are still pending for the ISBMT. What would you as a
Yes, I'm coming
organization-
to that.
Yes,
Can you
please.
just move to the
Yes.
last slide? No, there was another slide. So what is our request for ISBMT actually? We just made it a direct request because I knew Dr. Revati was here. So we said, can you help us redo the standards for what is a good pediatric transplant center? And I think the patient group will all have good inputs in that too. But it is very important for us to know and understand that these are currently the standards we accept in India for transplant centers. We also want an update on the guidelines. What are the indications for pediatric cancer HSCT and which type? And we used to have the current guidelines that we have are what we call red, yellow, green, indicated, maybe indicated, not indicated at all, so that we knew how to do it. And we know we need a refresh, but we don't think we need to create our own body of advisors when we have ISBMT now. So we feel that ISBMT should do that. You talked, Neerad, about patient-centered education content. Can we do something so that we can individualize to malignancies? You may be individualizing to thalassemia or other conditions, immune deficiencies, etc. But really, what does a family need to know? What are the types? How to manage post-op? I guess I'm sure you have more inputs. You particularly, young man, will have lots of inputs on what do you want to read about, which often we don't address young people. We don't talk, our patient education material does not address them. I find all the patient education material is only addressing the doctors or the patient groups. But actually it needs to address people. So you please be vocal about this. What to expect, what are do's and don'ts for families and what help is available. This is what we think should be in the patient-centered material, and these are our asks. Thank you.
Thank you so much. That was wonderful. I think she through her work as well as the talk. She's touched upon so many areas at one go, not just the patient support that they are offering, but the patient advocacy that is the undercurrent of the whole work, body of work that all of you are doing, all that she is doing through Can Kids, and I'm thankful for all those inputs. And we'll take this forward as soon as possible in a more organized way. Next slide. I invite yes, Shobha Tuli ma'am to share her thoughts. She has been a pioneer in working for patients in thalassemia, so I welcome her.
So, I'm Shobha Tulli, and currently I'm Secretary of Thalassemics India. The Thalassemics India was the first NGO which was established in 1987. And also at the moment, I'm Secretary of the Thalassemia International Federation. And here I would like to just mention that it's a very proud privilege for the Indian thalassemia community that somebody is able to represent the international body and elected there for the last more than 22 years on the TIFF board. And now I'm currently the Secretary of Thalassemia International Federation and as well as the president. You can see that. I won't go into all the details. What I want to share here is that it is because of what we are discussing today is the advocacy. So one, if we want to, our advocacy only translates into activities and the results if we are able to make the union ministry and the state governments hear to the patients and the parents' body. And I am very happy to share with you that at this moment, hemoglobinopathy, especially the blood disorders like thalassemia and hemophilia, the ministries are listening to us and there are many improvements that have taken place. Next one, please. So these are just, I won't go into the details because of the shortage of time, but this is what we have been rewarded. And we feel so privileged that there are associations and there are the governments also who acknowledge our services. Next one, please. These are few pictures. Next one, please. The recent one was an acknowledgement in Jammu by IAPPHO chapter. And these are our just the current projects which we are running in Delhi in association with Indian Red Cross Society. We have opened up a center and it's a joint project where we screen all the blood donors who come for to donate blood and we do the thalassemia screening as well. Then this is the Helping Hand projects which was started in 2002. We help the underserved patients by giving them free of cost chelation medicines, blood leukocyte filters, infusion pumps, and the infusion needles. And it is for, I'm happy to share with you that there are many CSR funding that we have received, and it is going very nicely and in a continuous manner. And this is another Spreading Smile. This is for the children. This is a very important project, NAT screening project in Delhi. There are about 1,800 thalassemia patients. 800 of them are dependent on Indian Red Cross Society for their blood requirement. And we started a project in 2022, and we spent about 80 lakh of rupee invested in that to offer the NAT screen tested blood to the thalassemia patients. But then we exhausted our funds so that the project came to standstill. So now we are hoping it's at this moment and we have to enter into an MOU only. I'm keeping my fingers crossed that this project we are going to get some CSR funding, and this will be, we are looking at 14th of June where we'll restart this project. And of course, the blood donation campaign. And apart from that, we do the very successful eco webinars with the TIFF and with the PGICH Noida. And of course, about the Thalassemia Bal Seva Yojana, about which I'm going to speak. Next one, please. Thalassemics India is the coordinating body to run this project, which was started in 2017. And now it has entered the 8th year. So this project was started in initial discussions with the Ministry of Health, Family Welfare, Government of India. And then Coal India came in under the social responsibility. They started this project and now it has entered the 3rd phase, which will finish in March 2026. And we are hoping and we have been assured that it will enter the 4th phase also. And only 720 transplants. This is, I would like to draw the attention of Dr. Revati Raj because it is associated with what our expectations are from ISBMT. only 720 transplants took place in the 17 empaneled hospitals in 8 years. Look at the thalassemia numbers that we talk about. 1 lakh thalassemia patients, 25% of them can have a matched sibling, HLA matching. Even if we leave the adult ones, I am looking at about maybe 10,000 to 12,000 patients, and then the newborns added into that. So this is a very small number in spite of the funding that we get from Coal India Limited. And then is, of course, these are the expert committee members and these are the partnering hospitals. Next one, please. So this is, I won't go into the details. This is the criteria setup. This is the eligibility. Patient has to be below 12 years. The income criteria is there below 80 lakh of rupee. And then all the applications come and we screen them and then goes to the expert committee and then the ministry takes the final approval. Next one, please. And these are some of the possible sources of, in spite of Coal India funding, sometimes when they go to the different hospitals and because of the patients, the current status of they may need extra funding. So gap funding is being provided by the various NGOs and the trust and even the hospitals. Apart from that, Coal India, the PM fund and the CM fund, and there are many other yojanas, which are the very state specific, so the patients can avail of that. Next one, please. So this is our patient group expectation. So first of all, I want to thank ISBMT, especially Dr. Apte Revtiraj, for having us here. And I remember I was telling Poonam that we were invited at the Jammu conference also, and we feel very honored and privileged because it's not only that we want to impose our presence. We have worked at the grassroots level, and many of us are the sufferers, either through their children problems or the actual sufferers, survivors. And we know what is the pulse of the patient and the parent. The doctors see overall, they extend and give the medical, but we know what is going here. So we are the ones who can suggest what is expected. So from ISBMT, I have been there for yesterday, and Dr. Revti Raji, please, I want to make a submission here that, there are many books available, in our country on this subject, BMT and the gene therapy. It's in the form of book, and whom we are targeting through Thalassemia Bal Seva Yojana or the other. We are targeting the underserved, underprivileged patients. I would request ISBMT to prepare a 2-page or maybe A4-page kind of a document or a pamphlet, which should be patient and parent friendly. Means if they have to prepare for bone marrow transplant, it is very important they have to get the leukodepleted blood, the RN has to be in the place, what are the tests and all that. So when it also for the post BMT, 2-year survival rate is very, very important. And I have seen, and I feel I'm painful to share with you, 3 of our patients went home with the excellent survival and all that, but they came back with the GVHD, and 2 of them, we lost it because they were not told, they did not know what are the precautions they have to take in their homes. So our target group, and secondly, if we are looking at the rural areas, we are talking about the metro cities and all that. If we have to target that kind of a population, we have to make sure that there are doctors presentation, involvement, visits to find out who are these patients, and they can be the possible candidates of bone marrow. I'm not here to promote bone marrow transplant. I'm here to just share with our patients and parents family that this is the possible option. You have 2 options to go for the treatment plan if you want it, but then this is the possible cure which is present at this moment. And I'm very proud to say when I go out and visit and we talk about the Thalassemia Bal Seva Yojana, and it's a unique project which is only happening in India, nowhere else in the country. So thank you very much for having me here.
Thank you so much. Thank you for that impassioned talk. We are definitely on the same page as far as patient care is concerned, and patient-centric initiatives need to be more streamlined, I presume. So we are actually running behind schedule. Next slide. And here I invite Ruby Chawla ma'am to share her thoughts and expertise on behalf of Cuddles Foundation. Welcome, ma'am.
Thank you, Dr. Venkatesh. Thank you, Dr. Raj, and all present here. Good afternoon to everybody. Welcome to IPSPI. First slide, I think I had. Yeah. I am Ruby Chawla, founder and president of Indian Patient Society for Primary Immunodeficiencies, now known as Inborn Errors of Immunity. We registered in 2004. It's a national non-profit organization. We formed in 2004 to support those with primary immune deficiency disorders. Our mission and vision is to advocate for early diagnosis, treatment, access, and improved quality of life. We do have online presence. Our website is www.ipspiindia.org for resources and support. Now, talking about the inborn errors of immunity, actually, when we started in 2005, they were just 250 of its type. But now they are more than 550, they say. So now more and more have been included in this umbrella. And now we are talking of more frequently about BMTs. Actually, when we started, we came to know about the basic like XLA, hypogammaglobulinemia. And for that, doctors were telling that immunoglobulins work well for them. So they have to take it lifelong. That is a lifelong replacement therapy. And whenever we were going to the government for the support and all to talk about the advocacy for the support and everything, we were more focused on that how to get that treatment for the patients, which is an online ongoing therapy for lifelong. But slowly we came to understand that some curative treatments are also there for the medical emergencies, and that are SCID, like SCID, VAS, Wiskott-Eldridge syndrome, severe combined immune deficiency, CGD, chronic granulomatous diseases. So that was something like alarming. These patients have to be well advocated, well informed, well educated, well supported when they go through these BMT transplants. And like for what is our current challenge? Waiting periods for BMT can lead to permanent organ damage or loss of life that we have seen with so many patient families because it's a big financial burden for the family. Once the diagnosis comes up in the family, then after that they are totally broken down. And when they hear of the huge financial funding they have to arrange, it is just devastation kind of, means like they are totally devastated and they run to all the organizations what to do next. So first of all, I will stress upon this thing that patient should be very well informed, patient family should be very well informed, because sometimes it happens that even some institute tells them that it is around 12 lakhs or 15 lakhs. But still after post BMT, there may be certain complications and the medical stay is much more. And then huge expenses crop in, and then at that time also it becomes a huge burden for the patient family. So they should be well informed. The patient families have to be well informed before undergoing this BMT. And next is patient education, of course. And and there is some proposed solution for this, because recently there has been an amendment made in NPRD, that is the National Policy for Rare Diseases guidelines. Actually, primary immune deficiencies are listed in the NPRD, National Policy for Rare Diseases. And our patients who are undergoing treatment, that is, they are having this life-saving lifelong treatment of immunoglobulins, whether it is intravenous immunoglobulin replacement therapy now they are having. But now subcutaneous is also available nationwide because there are certain pharmaceuticals who are manufacturing this sub-Q also. So because in US and UK, they have shifted to sub-Q, but in India still, most of our patients are taking intravenous immunoglobulin therapy, and they are available, they can avail this therapy in the 13 rare disease excellence centers that have been marked nationwide. And these patients, they can register themselves there, and then they get the therapy there up to 50 lakhs, whether it is one-time treatment or it is lifelong. So lifelong means to say, like the government may enhance this having all the data, because the data access is not that good. But now, like as the rare disease excellence centers have been marked, because that is shared with the ICMR also. So now, like coming to BMT, bone marrow transplants.
Excuse me.
Now,
I can only give you 1 more minute.
Okay.
I need you to tell us what you would like as a patient support group
Sure.
initiative to address that.
yes.
Your inputs quickly.
Okay. So, like, there's an amendment to made in NPRD guidelines to allow COEs to outsource and establish memorandum of understanding with government or private hospitals. So, government or these government or private hospitals where the facilities are there for the BMT, they can contact the centers of excellence, and then the patients waiting there can get the treatment in these government or private hospitals. And then about the funding strategies, if we say establish,
I'm so sorry, I'll have to cut you short.
okay,
Can you give me quick inputs that you would like the patient support group by ISBMT to address in this group of patients? Quick 2-3 pointers that you would like us to work on as a ISBMT.
yes, sure. So, like about this, like that's a good question, and I would like to. First of all, I'm really thankful to Dr. Revati Raj, because she has been associated with our organization from a long time when we started in 2005, and first of all, addressing the patients is very important. So patient information, we require more and more patient information, because usually when the patients are coming to us that this BMT has been means advised by the institute or the doctor, then the patient is having very less information we see. And even we are not able to provide that kind of information which is needed. And first of all, patient information, then patient education, and then working with the centers of excellence so that the patient waiting time is reduced, so that permanent organ damage or loss of life is not there.
Thank you very much. These are very important inputs for all patients who are struggling with immune deficiency. Thank you so much for your guidance and the body of work. Next slide. Next. Yeah. I welcome Shri Priya ma'am as well to talk to us about the nutritional aspects and her inputs about what we would as ISBMT take this forward. The mic. Yeah. Okay, thanks.
Thank you so much for this opportunity. Thank you, Dr. Revati. Thank you, Dr. Silky, and ISBMT as a whole. So we are Cuddles Foundation, and we primarily take care of a very, I would say, primal need of all living life, that's nutrition. And how do we do this? We basically do this by bringing medicine and nutrition together. Very often we see that patients have fundamental questions that they ask doctors: what should we eat and what should we not eat? And because doctors are dealing with so much of stuff, that this is something that goes unanswered. And nutrition is often an unrecognized pillar of medicine in cancer. And you would also see a lot of abandonment happening because of undernourishment. What do? We enable doctors. We enable them to do their work by taking care of the nutrition aspect or the nutrition questions of patients. We do this by placing specially trained pediatric oncology nutritionists in each of the pediatric oncology departments. We work with primarily government hospitals. And our nutritionists go through intensive training on nutrition because pediatric oncology nutrition is such a niche subject that's not taught in colleges. So we fill that gap. We ensure that they are going through rigorous training the moment they come in, after 6 months and every year. Other than that, an important part is we also provide aid. Writing a prescription is one thing, but ensuring that they actually get the food that they need or the supplements that they need. It could be total parental nutrition bags, or it could be NG tubes, or the nutrition supplements is something that we all provide. Next. Yes, yes. I just have, I'll take another, say probably 1 minute, 20 seconds. I'm so sorry. Yeah, you could time me.
No, thank you.
So this is a program that we primarily do, wherein our nutritionists go in, constantly monitor the children, go through the side effects, tweak the diet depending on the side effects. So it's not a cookie cutter diet that all children get. Next slide, please. This is our footprint. We are in about 40 hospitals across 14 states, and we have about 55 plus nutritionists, and this is counting. Next slide, please. This is our strength. What we do is we have an app, but I would say it's a tool. This is not available on any Play Store. This is something that all our nutritionists are enabled with. They monitor a child right from the time they come in until they leave or they are cured of the disease. So it's a longitudinal view of the data of the anthropometry and the diets they use. So what this enables us to do, and that is going to be the crux of what we are requesting from ISBMT also, is the nutrition education. Like I was part of one of the webinars, and what we realized across our hospitals is the questions that patients ask is all different. And the information that doctors have across BMT units also differ. So sometimes what happens is what we provide, what the knowledge that we tell patients is something that's not probably what doctors agree to. So one thing that we would definitely offer is the wealth of nutrition knowledge that we have is something that we offer ISBMT. At the same time, we would love for ISBMT to do research and guidelines into diets for BMT. I mean, we've been part of the IAPN guidelines, the ICCI guidelines that is being written right now. And we see that BMT, the nutrition that's given during BMT, is a small part of it. But this is something that I would request for us to deep dive into. And that takes me to the final slide. So please contact us for information, and we are always here to help you. Thank you.
Thank you very much. It was very succinct and very informative, and we'll work on these. Now, I'll invite my last speaker, Vinita Menon ma'am from Friends of Myeloma Foundation. Many of you may be aware of the stellar work that Dilip Mewada did in advocacy, patient support in this area of Myeloma Foundation. We unfortunately lost him recently, and I invite her to share her memories and pay an homage to Dilip Mewada. Unfortunately, we are very short of time, so I call upon Vinita ma'am. Yeah.
Good morning, good afternoon, I think. It's a pleasure to be here and the opportunity given by ISBMT to represent Myeloma Friends Charitable Trust. Before, I think we are running short of time, so I'll just take a few minutes. I think I'm not very sure how many of you would have known Dilip. And Dilip has been the founder trustee of Myeloma Friends Charitable Trust. We started in 2012 when Dr. Saik, when he was undergoing a BMT and he was paralyzed waist downwards. And at that stage, he was asked to counsel Adesh Srivastav. And our journey started from there. So I am one of the core trustees also of Myeloma Friends Charitable Trust, a 14-year-old conqueror and a long journey. So talking about Dilip, just a few words. He was a person who changed the perception of how we look at myeloma. Myeloma, as you know, is a marathon, not a sprint, and it's a long-term situation. When you are given the opportunity of being told that it's treatable but not curable, it's like somebody pulling the rug down your feet. I've had that feeling, but he was the kind of person who says, so what? Let's overcome it. And that was his statement that has got a lot of people through their journeys, through the kind of treatments that we've had, through ASCTs, not having ASCTs, because I think we all know what it is to take the decision to have it. Dilip has been more a larger than life person, inspirational, motivational, and he never believed in fighting a war. He always believed in conquering a war. He's underwent, I would just about say, everything that myeloma can offer him, right from 2 transplants, relapses, a 17p deletion, daratumumab, then a CAR T, and the CAR T was actually very successful. But unfortunately, we lost him exactly 1 month ago on the 4th of April. Today, it's, I think, a coincidence and a wonderful coincidence that we are giving him a tribute just 1 month after the person, after he has passed away. In his own way, Dilip has touched many, many lives. And I stand here in all humbleness and gratitude to have known him, to have known his larger than life persona and his perception of how he felt that communication in cancer needs to change. So I would say this is a little on Dilip since we have there's a lot to say, but he's been a wonderful inspiration and the pillar in myeloma, understanding myeloma and being a pillar of support for the myeloma community. So thank you. Uh, just a few this thing. Just can we just go back right in the beginning? Okay. Dilip's been an architect. He was a 14-year-old myeloma survivor, and he died because he passed away because of pneumonia, septic shock. Winners in Life and a Victor Award by the We Care Foundation. That's me. I have been a trustee and the chief operating officer for Myeloma Friends Charitable Trust. And as a profession, I've been a sports nutritionist, heading the Gaia Fitness Academy. Plus, I'm into financials also because I feel insurance is a major issue where most cancer patients have it. Okay, next. I'll just go through the kind. Okay, our aim and our mission has been to educate, make aware, and support cancer, myeloma patients specifically. That's been our journey. Next. We've had support groups all over India. We connect with hospitals, we connect with doctors. We also have patients coming in directly as referrals. We do a lot of emotional counseling through WhatsApp messages. We also have webinars every month. And for the last, I think, right from 16, we've been having webinars every month for nearly the last couple of years that we've had. We usually have it on the 10th of May, and we usually have a doctor taking it up. Next. These are our groups at present. So we have about 16 groups. We are in 16 cities. Next. So this is exactly what we want, patients and doctors. We've always had this issue that Dr. Saab hame time nahi dete hain, 5 minute bhi nahi milte hain. And we have lots of questions that come up. So communication between doctors and patients, how you communicate in which way you communicate. I think communication skills become extremely important. And I'm sure that ISBMT would be able to address that in the larger interest of everybody's communities, not only myeloma. Two, we usually, my ask, or rather our ask from ISBMT is that I think we need more information on CAR-T, which is the latest now. And since we are going into clinical trials, we would like more information on that that can be shared with our group members. We also would like any kind of information that ISBMT would share with for myeloma specifically that would help our myeloma patients understand and be empowered to lead better lives. So there are just a few right now because I think we need to consolidate a little more. But yes, from our side, whatever help ISBMT requires in terms of patient advocacy and patient support, we are there to give it to you. Thank you so much for giving me the opportunity to share this with you.
Thank you for the touching tribute to Mr. Dilip. And I've known him only for a very short time, but truly was an amazing person. So thank you for those touching tribute. So it's said, thank you for each one of you who've been here. And I know, as the Buddha said, thousands of candles can be lit from a single candle, and the life of the candle will not be shortened, is what he said. And you've lit not thousands, but literally, I think each one of you have been the beacon of hope for so many people. And it's amazing that you've decided to partner with us. From ISBMT, what I can hear from all of you is that there's a request that there is a full physician pool that can answer patient queries in turns, which definitely we'll look into. Webinars, patient-centered webinars, not just physician-centered. Maybe we are looking into linking your websites with our website, because if someone goes into the ISBMT website, where can I get more information on childhood cancer? Where can I get more information on thalassemia? And say that these are the links. Everyone's requested for minimum standards for transplant unit, which we are working on certainly. There are already existing guidelines that we've formulated through ICMR that we will share. Education materials which are patient-centric, which 100% we are working on. We in our group have two excellent resources, Mr. Raghu Rajagopal here and Ms. Jolly Thomas, who's our executive admin lead and operations manager. And they are very committed to taking this whole project forward. So I hope we can. Linking with the government schemes and reducing waiting times, and also communication in different languages. We come from such a big country and we're all speaking in English, which a lot of our patients cannot totally understand. And I think focusing on what to eat, I think that's very, very important, and engaging patients in research. And the last one mentioned soft skills training for all the caregivers in a transplant unit, which all of which we will definitely work on, communication and soft skills. And I think the final message is that we have to learn to be the heart and not just the brain, and look at the patient family as a whole and see what we can do for them in a holistic manner. We hear you. I can't make many promises because we are ourselves a fledgling organization, but I thought it'll be good to start in the right manner, in the right direction, so that we can grow together. If there are any communication gaps or something that you expected that did not happen immediately, please be patient with us. But we truly are excited to work with each one of you and get your feedback to see what we can do better for our patients and our community, and also be leaders in research to see what is better for the next generation. Thank you. I'd like to request Jolly, please, to come up and give a very small token of our appreciation. We're really happy that all of you came, and maybe after this session, we can sit down and talk a little bit more on what you want to say, because you are all extremely busy people and you have come a long way to be part of this meeting. And what best we can do, we definitely do from our side. But you have to be patient with us because a lot of people are involved in this. Thank you. So I'll now end this session, and thank you all very much. And we can take this conversation during the lunch break as well. We are here if you want to continue the conversation and maybe create a group that will take forward. Some of our patients are here who want to be the voice of what is happening for the future. And I'd like to now call upon Dr. Joseph John to talk about one of the important aspects after transplant, about vaccination, because so many patients have queries as to what vaccines are needed and what vaccines are not needed. And Joseph is a consultant at the Christian Medical College in Ludhiana, and he's drawn up a lot of our guidelines of ISBMT on post-transplant vaccinations.
Happy to be here. And so as Dr. Revati concluded saying that, science, it is not just a science. We are here because we work from our heart, and it is extremely important. The heart and the brain connects well, and it is extremely gratifying to interact with the patients. And that is why we have taken up this profession actually. And I'm so happy that these organizations have come forward, and I can see Can Kids, Dr. Poonam Bagai, Shobha Thuli, and Myeloma Foundation, and the IPSID Foundation, which is here, which is extremely gratifying that you are the link between us and the patients and trying to help. So from all what we have said, one of the cog in the wheel is about preventing infections post-transplantation. And if you look at the transplantation process itself, why we need to vaccinate is because the patients lose their immunity after the transplantation. It's almost like a rebooting of the immune system. And therefore, you have to educate the T cells and the B cells to produce the necessary antibodies for the antigens which they're going to see in the future. So if you look at the vaccination strategies, can you just change the slides from that side? Okay. So CDC recommends adult vaccination. It is not even just post-transplantation. In fact, all adults also have to be vaccinated to prevent infections. Now, we may say that vaccination can be expensive. Everybody has to get it, but it is much easier to prevent rather than treat. Next slide, please. So if you look at the ISBMT website, in our website, there is a provision for looking at vaccination protocols and the processes. So it is already uploaded in the website. It is there. And if any of the patients are going to ask, they can actually access it freely. Next slide. Even the national guidelines for hematopoietic stem cell transplantation for ICMR have adopted the same vaccination protocol, and it is already there in that also the same. So we did formulate this with a group over a period of 2-3 years, similar to what the Western is, and based on what we have in the country. Next slide. So essentially, if you look at how many diseases do we have in the world, is about 250 plus, where we know the bug. How many vaccines are available in the world? There are about 30 vaccines, which can be prevented. Now, how many of that we are using is only about 16 vaccine preventable diseases, which we are using. COVID is not in this list, and that will come as an additional addition separately. Why are these vaccines important? Because some of them can cause bad pneumonia, meningitis, polio, and hepatitis, and HPV virus can cause CS cervix. So these are proven agents which can cause short-term and long-term complications, and therefore we need to prevent it. Next slide. And vaccines are two types. One is live and non-live vaccines, toxoids. Live vaccines we avoid close to the transplant because that can itself cause disease. So therefore, avoid live vaccines. So if I have to say take home is avoid live vaccines immediately after the transplant, and other vaccines can be given. So when we looked at one study, literature search on various countries and the guidelines, these are the various vaccines available and what various countries are promoting. If you look at COVID last, Australia, UK are promoting that avidly, whereas India is not promoting that avidly now for various reasons, because we say it's a large population is vaccinated. I mean, we self-vaccinate, it's the herd immunity which will come in subsequently. Almost all the other vaccines we are following. And next slide, please. That is, I'm coming to Shingrix separately because Shingrix is the one which has been recently launched, and I have few slides on that. That's the only new thing I would say. So this is a vaccine sheet which we expect all transplant doctors or the nurses to print out. It is very easy to use. Otherwise, you'll forget when to give what to give. So when the patient first come, we will add that on the first dose, second dose, we plug in the dates there, and around that time they can come. So there is 1, 2, 3. Next slide. This is 6, 7, 8. These are various vaccines to be done. Now, if you understand, in India, some of the vaccines are not available separately. It is combined only available. For example, Hexaxim. I'll come to that. Next slide. So this is the exhaustive list of hepatitis, typhoid, and other diseases which we talked about. Next. And these are the live vaccines which we use. So love 4 live vaccines. MMR is altogether 1, and then varicella. Now varicella so far had only live vaccine. Now Shingrix has come as a recombinant vaccine which can be used. Next slide. Okay, just keep pressing. So visit 1. Suppose one sec. Okay. Okay, so if you go back and look at the visit 1, you concentrate there. You completed 1 year post allo transplant or 6 months post auto transplant. Remember, a maximum of 6 vaccines. 9 years to 26 years as males and females give HPV. So if they are not between 9 and 26 years, HPV is out, then 5 injections have to go in, which is Prevnar, which is a pneumococcal conjugated vaccine, then influenza vaccine on an yearly basis. Then Hexaxim has 6 vaccines within that, including hepatitis B. So visit 1, 0 visit, or the first 1 month of or vaccination, you get this 5 injections or 6 injections. Then second time, 2 months later, you get 4 injections. Prevnar, Hexaxim, hepatitis, HPV. The 4th month, you get 2 vaccines, 6 months, 2 vaccine, 10th month, 1 vaccine. If you remember like this, you are unlikely to forget. But otherwise, in a busy OPD, most of the doctors forget these vaccination protocols. Okay, next. Click on it, please. Yeah. At the end of 12 months, that is after 1 year, you end up giving influenza, MMR, and varicella. These are live vaccines, and therefore it has to be a 2-1-8 rule, which means 2 years post-transplant now, 1 year after the immunosuppression is over, and 8 months after the immunoglobulin is given. So if somebody has got immunoglobulin, giving a vaccine, live vaccine, can be counterproductive. If somebody has received rituximab 5 months after only vaccination, because the B cells have to be there to respond to it. Next. Okay, so at 13 months, the second dose of MMR and varicella will come in. Next slide. So what's new? Like Mrs. Vinita Menon asked, next slide. Yeah, so this is Shingrix vaccine. So just to give a comparison, don't bother about too much of the details, but essentially anybody more than 50 years should ideally get Shingrix. Shingrix is 2 doses, today 1, and 2 months later, up to 6 months, second dose. Each dose costs 14,000 rupees. That's about 28,000 rupees. So what is the advantage? We can come off acyclovir after a month after the second dose. There is a 70% protection that it will prevent herpes infection. So chickenpox. Next slide. So it is indicated in a 2-dose series, as I said, reconstitution, intramuscular only. Next slide. Okay, click. So you can, it should not be interrupted and continue the immunosuppression. Suppose somebody gets chronic GVHD and you have started the immunization, as far as possible, continue as long as they are not more than 20 mg of prednisolone. So that's important. If somebody is more than 20 mg of prednisolone, immune response will be poor and therefore avoid it as much as possible. Chronic GVHD, this happens. When somebody is on rituximab, give a 5 months gap because it is depleting the B cells there. So two things, rituximab and corticosteroid, except that everything else can be given together. Next. Okay. So it can be co-administered. Now, vaccine, suppose 5 injections have to be given. The patient comes and says, can I get 1 injection daily or 2 days separately? The answer is no. If you have to give, everything has to be given once. Suppose they don't want to get all the 6 injections on the one day and say, no, I cannot get more than 2. Then you stagger it at least a month later. So give almost 4 weeks for the response to happen. Do not give 2 in 1 week time, because then the second one will not have as effect as much as. Basically understand that when you give a small dose of vaccine, the body is recognizing that and trying to raise an immune response. In between, if you come and give another one, it will get confused. So therefore, it is to be given together, separated out at least 4 weeks. Okay, next slide. So again, this is just because Shingrix is a new vaccine. This is the side effects which they are mentioned. Almost every vaccine can have this pain and fever and myalgia. So that is not going to prevent us from giving any vaccination. Next. So continue the click, and there's no prior. So even if they had a prior episode of herpes zoster, Shingrix acts a value, but give it after a month or 2. So if somebody has herpes or varicella, can I give the vaccine? When should I give? The answer is yes, you can give it after 1 month of recovery. So essentially, there is no need to screen. You can continue the recommendation. Next slide. So the question then comes, post-CAR-T, can you vaccine? Post-CAR-T is essentially CAR-T therapy will ablate the B cells. Therefore, the answer is after about 3 to 6 months, when the B cells have started to come up, CD19 is 20 or above, and 4 is 200 or above, we can restart the same vaccination process. I'll stop there. Thank you.
Check with you that, I mean, is the responsibility of the transplant team to ensure that all these vaccination schedules are done?
Yes.
Yeah.
It is.
So you would do it.
Yes.
Regardless of
But,
whether
you know,
the
understand,
patient knows.
I mean, as much as it is important, please understand that in a busy OPD, generally the thinking frame is to address the problem.
Yeah.
Prevention is usually takes a second step.
Yeah.
In the Western country, it is usually taken by the nurse coordinator, BMT nurse coordinator. But
Okay.
that simple sheet which I have created has done best with me, because I know one year over, I have to have a thinking okay there, thinking that, okay, this must get the printout there and put it there, then only it will happen. Yes, the responsibility of the physician, but it is easily forgettable, and therefore we must reiterate. And if the patients are educated, it is another way of reminding the doctor that, yes, what about my vaccination?
I'm just entertained because for so many years of doing a BMT project, I have just learned this today for the first time that everybody got immune suppressed and now they all need to do vaccinations again. I never knew it.
In rejection. So basically, go by when is the last cyclosporin given. Okay. So 1 month after cyclosporin is generally we start all non-live vaccines. All live vaccines after 1 year. Ideally, they are expected to do. We have now made a BMT diary in which it is incorporated well in advance. But even if they have a diary, they are not going to read it. That is the human nature. Unless there is a reiteration and a reminder. Yes, we must do it and we must promote it. Yes. Post BMT, yes. Correct. Correct. Absolutely important, because some of, see, if I did a costing of all the vaccines together, suppose this is taken in a span of 1 year, and all the vaccines put together, it will come to about 60 to 70,000 rupees. So though it is staggered out, it is a burden. So if there is provision to, support, it is extra. Otherwise, what happens is this is not an acute problem, and therefore it gets forgotten or axed. Yes, absolutely. Okay, sir.
I'm happy to learn that the Punjabi accent has been all diseases across Hello, Auto, Carti, English framework were to remain as is.
Yes, yes. So we went through and made it, there may be some subtle difference here and there. We went by other guidelines and looked at it, what is convenient. Otherwise, we'll forget. That's why the 2 monthly framework which we put in. And yes, it is the same. Yeah, auto starts at 6 months. In a haplo, when we are taken off the immunosuppression quickly by 100 days, then we are bringing it at between 3 to 6 months. The idea is bring in a preventive measure for them, the immunity booster, as early as possible, as soon as they're off immunosuppression. So allo transplant for thalassemia also, we started 1 year. But for some reason, if we have tapered and stopped the immunosuppression at 6 months or 9 months, within 1 month, we start the immunization.
Like a jack and mixer or something. How does that work?
Yeah, so there is no recommendation on ruxolitinib right now. But when I say ruxolitinib, when somebody is on ruxolitinib, is already on steroids or he is already on CNI. Therefore, so it is a question is, suppose I have started the immunosuppression, vaccination, patient develop GVHT, I continue the vaccination. But if the steroid goes up beyond 20 mg, then I stop, restart everything once it is done. So then you cannot say I finished, one dose here and therefore I'll start from the second dose. You have to start from one again. Okay. Thank you very much.
Thank you so much, sir, for an enlightening talk on a very important aspect post transplant, and that is vaccination. So we will move on with the third session of the day and the last session, which is on a very important, I think we cannot underestimate the importance and existence of chronic GVHD when we are talking about transplant. Because although we might think that the incidence is not as much, is a rare complication, it's not as rare. And in terms of the profound impact that chronic GVHD has on the quality of life of patients, we need to talk about it. So, can you change the slide? Okay. So can I have the introduction slide of panelists? So I would like to invite the panelists on stage. Please. I'll start with the introduction in the meantime. So what do we mean by GVHD? GVHD is graft versus host disease. And it is actually the immune response which is mediated by immune cells of the donor against the patient. So when the donor's immune system attacks the patient's organs, It is called as graft versus host disease, and it is basically of two types, acute and chronic. Conventionally, we used to classify it into acute or chronic only on the basis of the timings post-transplant when it used to happen. But now there are new criteria for chronic GVHD based on the clinical features, histopathology features. So usually the acute GVHD, it happens before 100 days post-transplant. And the most common organs affected are skin, gut, and liver. And this is characterized mainly by inflammatory process. As compared to chronic GVHD, which usually happens from 3 months to 2 years post-transplant, and the ongoing inflammation, low-grade ongoing inflammation, and the process of fibrosis. So this is characterized by fibrotic damage. That's how it is different from acute GVHD. And even the organs involved are different. So practically, can you change the slide, please? Yes. So practically any organ can be affected with chronic GVHD, but the most common organs affected are eyes, mouth, lungs, skin, then even the genitalia and musculoskeletal system. So the kind of manifestations that we have in chronic GVHD are related to fibrosis or scarring, like dry eyes or dry mouth or whitish patches in the mouth, and then similar features in the genitalia. And when we are dealing with lung GVHD, there can be restrictive lung disease kind of features. There can be breathlessness. So skin, you can have scarring of the skin, contractures of muscles. So these are some of the presentations of chronic GVHD. Slide, please change the slide. Yes. So what I want to highlight here is why we are talking about chronic GVHD today is because it runs a very long course, unlike acute GVHD, and requires ongoing medications, and thus it affects the physical and emotional quality of life of patients and the families both in a big way. And therefore, the management involves allied health professionals like dietitians, physiotherapists, and psychologists, apart from the other medical specialities. So, it's okay. So I invite all the panelists on stage, and I will introduce them. Yes. So I'll introduce Dr. Intizar Mehdi. So Sir is a hematologist at HCG Bangalore. Then we have Miss Lakshmi, who is a nutritionist, who is psycho-oncologist at NH Bangalore. Then we have Dr. Vasundhara. So she is also hematologist from Bangalore, Kedwai Memorial. Yeah, and we have Sharat sir. I think he needs no introduction. And Sharat sir is a senior consultant, clinical lead director, adult hematology, and clinical director and chairman oncology at Mazumdar Shaw Medical Center, NH Bangalore. And we have a special guest with us today, Mr. Vikas. Please come. So Mr. Vikas Chandra, so he is parent of Chirag, who is with us today. And Chirag is here with his parents and his sister. And Chirag is a survivor of bone marrow transplant. I think I'll start with the questions, and then Mr. Vikas, you can tell us more about your journey. So. Yes, definitely. So, Mr. Vikas, can you tell us briefly about your son's transplant journey and
Yeah. Yes. Yes. Okay. Yeah. So this is when Chirag was 3 months old in 2007, when we came to know that he's suffering from beta thalassemia major, and the world turned upside down for us. And we wanted to understand what is this, how we are going to manage this, treat this. There was less of information where to go. And also we got in contact with pediatric hematologist. And then we started this transfusion process and then started keeping a tab on, how to treat this permanently. Is there a cure and what's happening in the cure world? And then got in touch with Dr. Revti, and in due course, we were always in touch with her, what's happening in the cure side of things. And while we continued to keep him healthy, transfuse him, and keep the iron and other parameters in check. And when we came to know about the donor, a matched donor, first with his sister, it did not match. So we had to go with a worldwide search with help of Dr. Revti and all the transplant centers. We were searching worldwide, and we came across a donor, 100% matched, and that's where relevant to this topic. We had very little information. What happens? How unrelated match, what happens, how is the process and everything. And that time we decided not to go with it, and because we were very scared as usual, and we were not knowing, not much information was there. And cut to after 2 to 3 years, when we checked again and we reinitiated the search, we got the same donor again. And by that time we had a lot of information, and Dr. Revti patched us with another patient or the survivor. And that's where the confidence started boosting. So information is very, very important. How do we share from one to other? So we got the information from another survivor. We are passing on the information, which brings the confidence, knows what can happen, or it's not the same for everyone, but a lot of information gives you courage and hope. So that's where, and then we started the process, and rest is history. He's here, 18 years of age. He's giving engineering entrance examination, and he's doing good. Thank you.
big round of applause for Chirag. Thank you so much for sharing that. So, can you move this? Okay, we are done with this now. Yes. So,
I mean, it was the decision was not that personally. Just medical takes too much time. Yeah, that's why.
okay. So, okay. So, Dr. Intezar, so do you generally explain the patients about the complication of chronic GVHD as a possible complication after BMT at the time of taking consent?
Yeah, definitely yes. First of all, just to add on to Dr. Sharath sir, I am fortunate enough that the patients I have transplanted, both of them for leukemia about 3-4 years ago, both of them have joined medicine. The boy, the boy is in third year and the girl is in second year. They are studying in Bangalore. Both of them were leukemia. I have transplanted 4 years ago, and they have told, sir, you just wait, we are coming. So I hope and pray that I am there by that time when they get trained, because medicine long training process, and by the time they do post graduation and super specialization, I hope I am there with them at the same place to continue. Uh, no, but if he wants to pursue engineering, definitely why not? This is there. But yeah, sure. now AI coming in, and there are so many other things, you know, CAR T and so many other things where medical and engineering people are collaborating so closely. Okay, regarding the chronic GVHD part, yes, definitely. As most of us as transplant physicians, when we are doing the initial counseling, after telling the good part of the transplant, that for example, if you are transplanting a thalassemia or leukemia, we say that, let's say 6 months, 1 year after the immunosuppression is over, you are cured for all your life, you are not on any medications and all those good part. But we also definitely mention to them about infection and also about chronic GVHD, because all of us know, depending on what type of transplant we are doing, match sibling rates will be lesser, mud it will be slightly higher, haplo it will be more higher. So we need to definitely explain to them that chronic GVHD, like Dr. Silky already briefed here, that it can involve so many organs in addition to skin, mucosa, eyes, liver, gut, lung, and musculoskeletal involvement. So we definitely need to counsel them that, but we need to be positive, telling that the risk of chronic GVHD is lesser, and there are a lot of strategies which we can do to mitigate that risk, to bring it down. But definitely, I mean, if it happens, that's a nightmare for all the transplant physicians and also for the patient families. But we need to definitely tell them about this in the beginning.
Yes, I think it is important to highlight that this can be a possibility so that the patients are not taken by surprise if at all they land up getting this complication. Yep.
Yeah. Yeah, like she mentioned, see, usually once the engraftment happens, let us say after 2 weeks, after that, any point of time within the first 100 days, we get acute GVHD, which typically targets skin, liver, and GI. That means diarrhea, they'll have jaundice, they'll have skin involvement. That is called as acute GVHD. That happens for the first 3 months, 100 days. And then it can actually persist and become chronic over a period of time. And that can go on for 6 months, 1 year, 2 years, or sometimes it can go on for all their life. So it's very important to actually reduce the risk of chronic GVHD, because, for example, somebody is a thalassemic, we know they are transfusion dependent and chelation and so many other problems as they grow their quality of life. But if you transplant them, you make them transfusion free, but you give them bad GVHD for all their life, then it's like one chronic disease you have taken over and given them another chronic disease, which is not our goal. So that's why, as much as possible, we try to prevent the risk. But definitely, we all know that in spite of all the strategies, still some patients will continue to get some amount of chronic GVHD.
Next slide. So, Mr. Vikas, coming back to you, I think Chirag got it an year after transplant, if I'm not wrong. So what was your first reaction as a parent? I think it's very difficult when you get to know that after an year of transplant, when you must be expecting that Chirag is now going off medications and he would possibly lead a normal life like his peers. So what was your reaction when you got to know that the skin rash which he was having was something called as chronic GVHD?
Yeah, so to us, it was a surprise thing that, what is this? First to know about it, like what information and what is the treatment or anything we need to do about it, or just forget it. And that's where Dr. Revati and the team guided us in terms of what it is, how severe it can become, or what we need to be on top of it, what we need to give as a medication, or that is the time where the medication has to taper down. So we kept it little longer, and it started with few spots to more over the body, and it was kind of little knowing about it, that how far it can go and what it has an impact of on the permanent cure. Is it having an impact on or not? So yeah, information again is key to understand what needs to be done, and we just followed what needs to be done. And on back of my mind, it was like, is Chirag impacted by that? Does he think that what is this? And is he thinking, is he shy about going out with the sports and things like that? I did not notice. He can share what he thought inside. But yeah. But I didn't see any change in his behavior, or he was feeling shy about it. And he took it based on the protocol and the process, what needs to be followed. and we kept ourselves informed and took care of it. And then when it started dying down, it was like mark is still there, but when doctor says that yeah, it is settling down, that gives us a lot of. But the final goal of being transfusion free and cured is on top of everything, and then we are living with it. Yeah, thank you.
So next slide, please. So, Dr. Vasundhara, if you could please tell us, how do you prefer to treat skin GVHD? Because as we know, there is systemic therapy, but there is a role of topical therapy here as well.
So, as Dr. Intizar mentioned before, we will try to prevent chronic GVHD as much as possible. How do we do it? By taking good skin care. For example, keep your skin moisturized with a good moisturizer. Yeah, I can see Chirag and his mom, I think, nodding vigorously. Yeah, 2 or 3 times a day, a good moisturizer. Then a barrier on top of it, usually a petroleum jelly like Vaseline jelly, or simple coconut oil on top of this moisturizer. These are minimal things so that you cannot mitigate completely the chronic GVHD.
About the treatment, can you highlight?
Sure. The treatment wise, we will start with topical treatment, starting with the topical steroids like mometasone or clobetasol. All these are topical steroids, and sometimes topical calcineurin inhibitors like topical tacrolimus. If with that it doesn't subside, then we go for the systemic therapy with the medicine you take by mouth, what we call as oral steroids, and the oral calcineurin inhibitors like cyclosporin or tacrolimus. These are the first line of therapies. Now, the biggest thing with the chronic GVHD is being patient. It doesn't go away right away. It takes time. So your doctor is going to help you out to figure out, is it the time to change to the next one? For example, switching from the first line to the second line of therapy, you give time and then switch. For example, there are newer medications like JAK2 inhibitors like ruxolitinib or Jakavi, then ibrutinib, imatinib. These are the medications you take as a second line of treatment. And anyway, prevention is better than cure. So go for the prevention first.
Please change the slide. Yeah. Thanks for that, Dr. Vasundhara. So I would like to ask Sharat sir that is there any difference in terms of incidence or management of chronic GVHD between adults versus pediatric patients? And also in terms of any specific issues which might be faced by adults and not by children, or by children and not by adults?
Yeah, so I mean, the disease per se, doesn't differentiate. Just a note here that, we sometimes just only make a difference when it is a malignant disease and a non-malignant. So when it is a cancerous disease, sometimes we need a little bit of that GVHD, which we call as graft versus leukemia, and we allow it to happen. And that's something we kind of prime the patient and say, it's actually good for you because it's preventing disease from coming back, which we don't want in a non-cancerous disease like thalassemia or aplastic anemia. So that's the first thing. So here we want zero chronic GVHD, and all the preventive measures are done. So that's the first thing. Generally, if you just look at adults and pediatrics, I think children, handle this better, recover faster compared to what we see in the adults, because there, the musculoskeletal ability to, again, come back to normal is also limited. Okay, your ability to regenerate is lesser. So the deficits tend to stay a little longer. There's more stiffness, there's more pigmentation, there's more joint restriction of mobility. That is something which you tend to see more in adults versus children, which we hardly would encounter. Okay. The skin pigmentation also sometimes can be a little more in adults, where the hypopigmentation can be quite severe. So we've had patients who almost become totally, like vitiligo, totally, fair, which is not the good fair, and it becomes embarrassing, and they tend to be having to go and have more social appearances. You're going for a job. So these are things which come up. And there are psychological issues also which come up sometimes, which need not come to us directly. It's there in the background. Sometimes the caretaker brings it up, and that's why we call in for support from others, which is not very, obviously told to us. So these are a few things which pop up more in the adult population versus the children.
I agree with you, sir. So I think I would like to add just one more point, that pediatric population is thought to have slightly lower incidence of chronic GVHD as compared to adults. So next slide, please. Yes. So coming back to you, Mr. Vikas. So I think we can ask Chirag himself. He's there. So, Chirag.
Suggest that.
Like, please come, Chirag. You can sit with your father. Yeah. So, Chirag, Mr. Vikas told us about his perspective, his reaction when you were diagnosed with skin GVHD. But how did you deal with it? Was it difficult for you, considering the chronic skin rashes that you were having in terms of catching up with your peers, reintegration into the society? And did you face any taboo, any body image issues that
I mean, like not specific. First of all, like when this chronic GVHD incident happened, it was kind of a surprise because it happened about a year later. So till that time, I was like, okay, now everything's done, most like off medications and all that stuff. Then suddenly, this thing, the skin GVHD part came up. I wouldn't say it was very hard to deal with, but yeah, it spread pretty quickly. So like there was some basic medications like cream and all that stuff. We used to do that, and as far as the society part is concerned, yeah, I did face a couple of incidents where people asked me about this, like, what is this? Even till date, if the people still ask me about these marks. Uh, so yeah, it is not, I would not say troubling me exactly, but yeah, it is there, but I don't really mind it because the major goal was to live as a normal person, and this is just a small scratch in the part of it.
Oh, wonderful. I really appreciate the courage with which you have faced this and overcome it. So, big applause for Chirag. So, next slide, please. Um, go back. Go back, go back. Yeah, okay. Next slide. Sure, ma'am.
No. Not really, I don't think so.
Criteria is put down already. Okay, go ahead.
Okay. So, Miss Lakshmi, so Chirag faced it very bravely, but if you are dealing with a patient who is facing these issues, how would you like to counsel?
I think he's covered it very brilliantly that uh, our goal as a psychologist is to remind them the goal of the treatment, that body image issues do exist. We can't neglect them. But at the same time, their goal here was to be transfusion free and to reintegrate back into the society. So, as a psychologist, our initial point is to restructure their thought in that manner and put the bigger picture and help them with coping strategies to go back to normal life. And again, like Sir mentioned, psychoeducation here becomes a major part, having adequate information which is easily understandable, and how do you answer questions when somebody asks you what has happened, and equipping our patients as well as our caregivers to be able to face the society, to be able to give answers. And even like how Sir mentioned, providing a bridge between the treating team and the patient party becomes a place where we play a very crucial role, because a lot of time our patients have questions which seem very simple and they do not bring it up to a physician maybe at the initial time of treatment. And that is where I feel like we play a role of providing that space, I would say, more than counseling, providing that space for us to address and empower our patients as well as their family becomes our major role as a psychologist in this setting.
Yeah, completely agree. So I think it's more of educating the families and friends around the patient who should equally participate and support the patient in whatever obstacles they are having in reintegrating with the society. Great. So next slide, please. So we will talk about oral GVHD here. So there is a 10-year-old child with relapsed acute leukemia who underwent half-match transplant with his father. And the immunosuppression was gradually tapered off. And at 6 months post-transplant, while he's off immunosuppression, he developed some sores in the mouth along with some skin rash on the trunk. And within another week, he also develops whitish discharge from penis. So he was diagnosed with chronic oral GVHD, skin GVHD, and genital GVHD. So this chronic GVHD is known to behave like a syndrome. It usually affects multiple organs at a time. So that exactly is what is happening with this 10-year-old. Next slide, please. So Dr. Intizar, if I may ask you, how would you like to manage this patient?
Like Sharat sir mentioned, if we are dealing with a malignant problem or benign problem, the management is little bit different. For example, if this was a thalassemia child and we had done haplo, we wouldn't have tapered the immunosuppression so fast because we know the risk of GVHD is there. We would have given little bit of prolonged immunosuppression. But because this is a leukemia patient, we want little bit of GVHD to come to prevent against the relapse. That's why immunosuppression has been stopped at around 6 months, and that's why a little bit of GVHD has come. But now, in addition to skin, there is mucosal involvement, oromucosal involvement, and genital involvement, and it is about 6 months post-transplant. So this warrants for systemic therapy in addition to the topical therapy for the skin GVHD, which already Dr. Vasundhara highlighted. So I would want to start the patient on steroids, oral steroids. We can use prednisolone 1 to 2 milligram per kg per day, but we need to be patient and wait for the steroids to work because it may take a little bit of time until we, like she already mentioned, in case there is no response to steroids, then we'll definitely consider other drugs. We have so many drugs where we can manage the chronic GVHD, but the most important thing is if this patient is going to respond to steroids, that is the most important thing for us because steroid refractory GVHD will have more problems, and if they respond to steroids, that's the best thing.
Absolutely. So next slide, please. I would request all the panelists to be brief, I think, in the interest of time. So, Dr. Vasundhara, quickly about what kind of food items can be offered to a patient with chronic mouth GVHD who is having a lot of discomfort in eating?
Okay. So to start with, concentrate on a well-balanced diet with a good amount of source of protein, about 1.2 to 1.5 gram per kg of protein in your diet. Be cognizant of that. And the calorie requirement will be a little higher when you have a chronic inflammation or a chronic GVHD. Keeping that in mind, about 30 to 35 kilocalories per kg of carbs in your diet.
Anything in the kind of food that you would
So
request?
the food in the sense, try eating softer diet, pureed food will be the first ones. And then if that too cannot be, stick to as close to your diet as possible. So start with the soft food. If that doesn't work, go for pureed food. If that doesn't work, then go in for the protein shakes or, the nutrition drinks. So with involvement of adding zinc, the micronutrients like zinc, vitamin A, D, E, C to supplement so that your body can fight these inflammation or chronic GVHD better.
Correct. So we have to keep a check on the weight, and we have to supplement accordingly. And soft, bland, non-acidic, non-spicy diet
Non-spicy is
is
the other.
what
And
is recommended.
this is where the nutritionist comes into play. One is
Yes.
for the, to tell us what kind of diet to be taken, plus a counseling source again.
Correct. So next slide. So the patient has been on steroid therapy. I think Dr. Intizar mentioned about steroid refractory GVHD, and that is exactly briefly, if Dr. Sharat sir, if you can comment on it, that the patient.
Quickly, just to add to what
Yes.
Intizar mentioned, no? So once you've done the local therapies, if it's not coming under control, you certainly will bump up your systemic therapy. Clearly, when you've taken off somebody quickly, the first thing you tend to do is add back the drugs which you discontinued and bridge the time for them to start working with more steroid. Because you want to quickly also take off the steroid because of the more side effect with steroids. Steroid has a lot of side effect, myopathy and a lot of infection risk and all that. So you're trying to come back to what you were or slightly bump up doses, generally what manages most of the time. Now, oral is something which is the most distressing one. If somebody cannot eat, then obviously it's very distressing to him, and then you start worrying about other things first. So that's our focus on enough of adequate local plus bumping up systemic. And my general rule is that allow whatever patient likes to eat as long as it's clean. That's the bottom line. You don't want to restrict. If I was already eating very less, you please allow him whatever he likes. Just give it. Something has to go in.
Absolutely, sir. So, especially if we are dealing with the pediatric patient, we would like to use the lowest dose of steroid on which the patient can be stable and add steroid sparing agents, as sir said. So,
Yeah, just symptomatic relief is something that patient look for immediately. So what can we do in terms of gargles or ice cubicles or whatever? What kind of symptomatic therapy do you recommend?
So yeah, so the gargles are always there, right? From an infection preventive perspective. And in addition, there's IT gel, there's easy treat solution, which is now available, which generally gives you symptomatically. All of them work on the theory that that little inflammation has to be suppressed. So, putting ice in the mouth, something cold, all that gives relief. Cold milk sometimes, works also. But that is all going to be transient, and that's why the frequency of having to do it has to be frequent, because it will not work for a, very long period of time. And sometimes people don't even like that little numbness induced by the anxiety. I think, he's there, he can tell us, people who experience this tell us that, and it's not a great feeling because it produces distaste. So sometimes you're countering it by saying that I'll give you a little relief. Then you say, I cannot appreciate any taste at all. It becomes a counter because then the intake drops. So the little balance. So we best allow the patient to decide what he thinks is most comfortable, give him all the options. And from our end, we generally try to bump up the systemic also because it has to work in parallel.
next slide. So, Dr. Intezar, what precaution should a patient follow while being on immunosuppression?
So the biggest problem with immunosuppressive therapy is the infection risk, and they are at risk of infection with bacterial, viral, fungal because of the immunosuppressed status. And sometimes the less virulent organisms which do not cause infection in the healthy people can also cause infection. So one of the things is the mouth care, appropriate lot of mouth gargles and all that, and eating good hygienic food. Like sir mentioned, my pediatric teacher, sir, who trained me in pediatrics, he used to, like, people come and ask ಏನೇನು ಊಟ ಕೊಡ್ಬೋದು ಮಕ್ಕಳಿಗೆ ಅಂತ. So my teacher used to say, doctor ತಲೆ ತಿನ್ನೋದು ಬಿಟ್ಟು ಬೇರೆ ಎಲ್ಲ ತಿನ್ಲಿ ನಮ್ಮ ಮಗು ಅಂತ. So sir used to say, my teacher, I am telling again in English because my teacher, he told me that except for eating doctor's head, let the child eat whatever he or she wants, because children are as such very fussy eaters generally, not at your age, smaller ones, 5, 6, 8, 10. So it's very difficult. So that's why let them eat whatever they are. But you are right, spicy food at all, they'll not tolerate. So we will. But for example, once in a while they want to binge eat on something they like, it should be okay. So a lot of mouth hygiene and all that, avoid eating outside food. Good homemade hygienic food is good. Daily bath and all those things. Of course, we will put them on some kind of prophylaxis. Like for viruses, we can put them on acyclovir, valacyclovir, or if the CMV risk is high, Valgan sometimes. And nowadays we have newer drugs like letermovir and all. And then for fungal infections, most of them will be on some kind of prophylaxis, either posaconazole if the risk is high, or simple fluconazole prophylaxis. Bacterial infection, except for being put them on quatrimoxazole prophylaxis to prevent against one kind of infection, pneumocystis. Otherwise, we generally don't put them on antibiotics. And they should have a very low threshold for identifying infection. We need to educate them. Majority of the time, fever comes. So fever is a friend. It tells us there is some problem, and they need to reach out the medical center that there is infection. But many times, fever may not be there. So sometimes, again, my teacher used to say that if the mother comes and tells you that there is something wrong with my child, then definitely mother is right 99% of the time. So believe in her because she is taking care of the child. So believe in that, and then assess the child very seriously. So these are some of the things. Yeah.
Absolutely. So we need to monitor for infections because these patients are on immunosuppressive treatment and they have to take the antimicrobial therapy very diligently to prevent the infections. Okay, next slide. So, Mr. Vikas, so we talked about how long this process of chronic GVHD can linger on. So, in the case of Chirag, how much time did it take for this process to die off? And yeah, if you can highlight on that.
Yeah, so since it was like, started with few spots to, so we lost track of, which one is new and which one is dying off. So we used to go to doctor and doctor used to identify, and like it started with 1 year post-transplant, and then another year or so when doctor said that, most of them are dead. And after that, we just compare, is there a new one? And we keep a tab on, is there a new one? And so far we have not found a new one. So based on that, we get confidence that it is dying down, but the marks are still there. And we keep the skin moist, though he doesn't listen. The bath point, I was asking him, you should take bath every day. So keeping that skin moist and, precaution in eating and everything. He had acute of the, gut and mouth also, which is not there now. And taking care of the spicy food part and all those things. Now he's eating everything. Yeah,
Right.
and we are taking care. Yeah.
Thank you. Next slide, please. So, Miss Lakshmi, this patient has been on treatment for 6 long months, and his mouth GVHD is still lingering on, and patient is just losing, uh, patient is feeling annoyed and is on the verge of giving up the treatment. So he's losing the patience to continue treatment. So how will you counsel this patient and the family? I think this must be a very common scenario that you must be seeing.
Definitely, in a lot of, especially with children, we do see
Yes.
them having a little resistance to come back to the hospital. In their head, when BMT is done, they want to go back home, and coming back every other week becomes something that they initially do not want to do. So our goal there becomes again education, and at the same time validating that yes, this can be frustrating, rather than questioning it, saying that why do you not want to come to the hospital, why do you not want to meet the doctor. Addressing what is causing them distress. Maybe in children, it might be waiting for a long time, or they don't get to meet their friends, they don't get to go out. So, understanding what is causing distress makes the picture quite different, because in a lot of cases, it's not essentially the medical treatment as such that is causing distress. Maybe it's the commute, maybe it's not being able to eat food. So, understanding what is causing that distress and addressing it, and at the same time enabling them to set smaller goals, maybe looking at one day at a time. So what is something that you like that you get to do today if you go meet the doctor today, or if you continue treatment, in very simple terms, like motivating them or reinforcing them, saying that you finish the doctor's appointment and then you get to do something. So that brings about behavior change in what, from my experience, I've seen in younger children to a large extent. This behavioral change and motivation brings out that sense of internal motivation that they want to do it, and it helps them seeing the bigger picture, which sometimes can be slightly hard with younger children. They're seeing the bigger picture of treatment completion becomes hard. So that's
Yes.
where we break it down into one day at a time and 1 week at a time, and how things eventually get better.
Taking one day at a time. I think that's the message.
Definitely. Definitely. Equally important is the child as well as the caregiver. A lot of times the caregivers feel a sense of exhaustion, which they do not want to admit,
Yeah.
because they have to be there for the medical treatment. So again, providing a space for them to express their concerns, or maybe even just sit and tell that, ma'am, we are tired, we do not want to come. And acknowledging that goes a long way in treatment adherence.
I think sometimes just listening to their concerns, their challenges patiently, that also helps.
One addition there, when somebody has a problem, you show them somebody else with more problem, then they realize how much lesser they have. So that's one thing which we tend to do. And one another thing I make a point in OPDs, whenever they come back, I say, come with some things which you want to ask. And each time I will allow one extra thing which was restricted till that point in time. That goes a long way, so that he's looking forward to coming and seeing me and asking, I want to ask 10 things, but I'm sure I'll get at least 1 or 2 from the doctor. Okay. So small things, ice cream, I want one little Coke today, I want to go out today.
Yeah. So that's a reward mechanism that. Yeah.
So that he used to go.
Correct. Yeah. Next slide, please.
I'd like to add here, we have just 30 seconds. And I think this is where patient support groups can really work very well, because patient-to-patient conversation on a skin-to-skin GVH, gut-to-gut GVH, GI to GI GVH, we've had several patients talking to other patients who have gone through it, and they're like, oh, I think I'm far better off. And I will get better. And I think this has worked very well for us.
So learning from each other's experiences. So, Sharat sir, we talked about the follow-up, but how frequently do you call the patients with active chronic GVHD, and is it important?
And it'll depend on the amount of GVHD you have and how, calling them back. If there's an infection, obviously they'll come more frequently. Otherwise, it's at least, every 1 or 2 weeks for sure. And then there are labs which we need to monitor, like, liver function counts and all of that. So it will be patient dependent, but that's generally a standard kind of protocol.
Do you do routinely viral reactivation panel, viral
So-
PCRs and all?
Yeah, so when you're upping immunosuppression and you have, see, that is why there's a lot of feel you get on a patient when you treated them from the day of transplant and you're following up. You can pick small, subtle things, when somebody is becoming a little sick and I need to kind of investigate a little more. Somebody's had previous CME infection and you're worried about a flare up when you're going up on the immunosuppression. So these are all kind of clinical decisions, and obviously whatever patient conveys, if he's had one bad, lung infection in the past and he thinks I'm getting something similar, you will immediately then,
So I think follow-up is really important for monitoring at what stage of GVHD the patient is and for titrating the drugs he is on, because we want to avoid under treatment and over treatment both in chronic GVHD. Next slide, please. So I think we can skip this in the interest of time because we all would like to join the valedictory function as well. Can we go on to the next slide? Yes. So, Mr. Vikas, I think this is the last question for this panel. So, did the sequelae, the skin pigmentation changes of skin GVHD that Chirag is having, did it pose any limitations in his activity, in his daily activity or his activity at the school? Did it restrict you, Chirag, in any way? And do you feel that you could have done something more that you would have wanted and you were not able to achieve it because of this?
Not really. I mean, in school I did everything possible. I was part of all the events. I was part of all the sports fest and everything. I don't think it limited my activity in any manner.
That's great.
And I would also like to add, limiting the activity. See, like it might limit your activity. Some people that have like more chronic GVHD that affects their muscular system or something like that. I would like to say on this thing, it's all in the mind. If you're happy, there's nothing that can limit your activity.
Wonderful.
Sorry, you want to say something? So this is a non-medical question. So I want to ask the experts that when you suggest when the patient is discharged from the hospital, and we know how the 2 year survival, time and the follow-up. So as far as the schooling is concerned, so what do you advise to the patient or to the family that whether they should avoid going to school for 1 year or what is the?
And like what you said in the previous talk, you want to have kind of completed most of your vaccination before you're sending back to school, college, or even to work. Because you don't want a risk of infection again to somebody who's been immunosuppressed for so long. So that's the general cutoff. 1 year is usually most of the time, because at the back of your mind, you also don't want somebody to lose another year of school, college, because this is very critical. And I've seen over the years that the moment I start telling somebody can get back, you can see there's a little, perk up and patients start doing better. Because now they're getting back to normal activity and they actually tend to do much better once you're back to school, college, whatever, rather than just sitting cooped up at home. So we definitely want to encourage that faster, but not at a risk to patients. So usually a year. And now with work from home, I think that's happening, helping people get back to work earlier at least.
Yeah, and last the achievement part, he's just given 12th exam, and he has given all the competitive exam. IIT Advanced is still pending, but in JEE Mains he got 98.5 percentile. That's, yeah. So yeah,
Wonderful.
waiting for advance
Excellent.
IIT Advanced, and then we'll decide which college he goes. Thank you.
Chirag is a really bright kid, and I think your inspiring story must motivate our audience who is watching this online and might be going through something similar to what you have experienced. So I would like to. Yes, please come forward, ma'am. Once.
That's very true. That's
I
very
think
true.
they must have been rock solid support for him to go through all this and
Can I just make one point?
would you like
Only
yes, yes,
30
please.
seconds. So I think transplant is a teamwork. And in addition to the transplant physician, BMT nurse, there is a nurse who follows up on the OPD, nutritionist, psychologist, and then, other specialists will also come. Patient support group, that's one of the most important things, like we mentioned here, because if they mix with other people, they will know that what are the problems on the other side. And also they would know that somebody who's having an acute problem now has gotten better, like how we are going through now. So that is a big this thing. And with lot of NGOs coming up, supporting the cause of bone marrow transplant, both thalassemia and others, I think these support groups and connecting to each other is very important. And I think as transplant physicians, all of us believe that we work as a family. And your family does not mean just your father, mother, and your sister. Family means all of us are part of you, and all the people, we have work as a family, and you are the most important person for that. And if people are positive like you, Chirag, then for sure, we can defeat all the diseases, we can win over all these battles, because like you mentioned, your main purpose was to defeat thalassemia, become transfusion independent, and have a normal survival, which you definitely achieved, and many more will achieve. So anything else which comes up, we just take it in our stride, because that's just a minor thing. And the way you are positive, okay, I have this problem, so what? So that's how it is. That's what goes a long way, I think. So big round of applause again for you, I think.
I mean, I feel, yeah, that's very important. One of the main things that helped me during my transplant was the positivity, and I feel it plays a very huge role. As long as you're positive, it can do wonders.
So, ma'am, would you like to say?
Yeah, as doctor said, it's whole family, not only we, but all doctors, all nurses, ward boys, everyone. Everyone is the part of the family, and the positiveness we get, not only from the doctor, from the ward boy also means a lot. That made everything to be positive.
I think every journey with the kind of myeloma patients we've also seen, one of the most important things is the positivity. If you accept the disease the way it is and don't make it define you, nothing ever will ever stop you from having a quality of life. So yes, hats off to you, Chirag. Hats off to your family. And I know a big round of applause for the caregivers, because they are the ones who need the most. And they are the ones who really are the ones who, I would say, face it every single day. Thank you.
Can you introduce yourself?
Hi, I'm Cherry. I'm actually Krishi's sister, and she was also a thalassemia patient. And we got to know about this, of course, from Chirag's dad itself. When she was going through it, we met uncle, and he like kind of told. So I'll just come that side, yeah. So yes. So, as I was telling, so my mom and Chirag's dad were like in touch regarding this topic. So that time, what was the thing? We didn't know anything about it. So we were not educated, and that was kind of very surprisingly for us to know how these things work. So after uncle told, we actually visited the Chennai hospital and met Dr. Revati Raj, and she has been immensely very warm and very, very heartwarming. Like, to be very honest, when such things happen, you kind of has a family breakdown into a very lot of things. You don't know what happens and what might can happen. You don't know. So all the support and all the encouragement, motivation of doing better in life and to see one doing better in life was given to us. And I cannot thank enough for that. So I'm just here to tell the doctors, nurse, even that 1 month where my mom and my sister were in the room during COVID and everything, each thing, like it can be anything, minute to the major thing, medicine, everything was taken care, absolutely amazing. Like we didn't have to worry about anything, and like everything, like medically, and everything was amazing, like physically, mentally, everything went on very well, and I'm very grateful here to be standing in front of all of you and just sharing that. So thank you so much. Thank you. And thank you, sir.
I've just given my 12th exam and I got almost 86%. And actually, this after the transfusion and everything, I have actually now almost I've been normal, and I'm happy that I've had this opportunity of my life. Yeah, I am normal. And I actually wanted to become a CA. So I've taken with BCom with ACCA now. Yeah. Thank you.
May you achieve everything that you want. Thank you so much for sharing your journey.
Yes, yes, please.
Yeah, sure.
I think the family pic one has to be done all the way. Take one.
Please.
Yeah, right.
Moms are a big support.
Thank you.
Thank you so much, everyone. So,
I think all the doctors also need to get it. Sorry,
please come.
Oh,
Oh, please come, Sharad sir. Dr. Vasundhara.
You do it first.
let's give you all a big round of applause. Let's see, Mama.
Everybody can be seen. Please come.
Some people can sit. Both of you can sit. Both of you can sit. Yes.
Please come. Everything, ma'am, please, ma'am.
Come both.
Yes, ma'am, please come in the center.
Revati in the front. So while all the doctors are special, this doctor is extra special. Just Dr. Devta. Please come for Lata.
So Mr. Raghu from ISB BMT wants to make a short announcement.
Hello, everyone. Thanks for coming to this event. I've interacted with some of you, so I'm an honorary executive advisor for ISBMT. So I'm happy to be more involved with all the patient support groups. So I will be happy to share my number and my email ID. For people who do not know me from the past, I'm the founder of Datri, ran it for 10 years as a CEO. And then I moved out into technology, but I've been an honorary advisor for ISBMT for the last 5 years. So I would love to work with all of you.
Yes, sure, ma'am. Let's do one picture. Please come for one picture.
Come for one more picture, so we're all there. So many of us. We let the kids come. I think the kids can, they are the heroes right now. Come, come.
You can come here, Swati. Swati, you can come here. In this chair. Yeah.
Thank you so much, everybody, for joining us today in this special patient support group meeting.
So just want you to announce, Dr. Anand has said, please come for the lunch because it's very special. Don't
Okay.
miss it.
So, I would like to, it's okay. Okay. I just wanted to briefly thank the MICE Ideas team and the ISBMT team for giving this platform, and the St. John's team for all the coordination and for the venue management. So thank you so much. I hope that something concrete, something meaningful will come out of this first meeting of patient support group representative.
Yeah, okay. Yeah. Swati, you can keep. She's a patient advocate. I'm glad you Thank you so much.
Thank you for coming. And I'm very sorry that we couldn't give you that one because somebody
Consolidate the summary. Thank you. Please.